nauseous, then we go CT scan, again suggestion is persisting, and then we go ahead and do. But based on the radiology alone, if we have done it, I think thought I will emphasize the point. We have done CT scan advise, are they right that advise of NAC? So is there any Dr. Naimis, can you take it that how we suspect gallbladder, any changes of malignancy on ultrasound?
So thickening of the gallbladder is what they see. Second is the lesion if they see, or if a polyp which is more than 10 millimeter, again they try to find out if it is.
So I still want to get back to port site metastasis. Dr. Selath and Dr. Vikram clearly showed that there is no benefit in resecting port sites in all patients, right? You said you resect the site which you know should be resected, or where the gallbladder has been extracted from. So at the end of the day, what is the recommendation? Do we excise ports? At one stage, Dr. Kapoor, if you can also participate, we used to say all port sites to be excised because the deposits causes are multi-factor ports, extraction port. So what is the recommendation?
Sir, if I say recommendation, it is just, we have 12 patients of port site excisions where we have done. What we follow, we are seeing that mostly these patients are having only epigastric port metastasis. I am not finding any patient having umbilical port metastasis. I am coming to that. I'm coming to that, sir. Based on that, and we are seeing that most of our people don't use bag. And when you are taking the gallbladder out and our pneumoperitoneum goes down, so sudden gush of the carbon dioxide brings more and more aerosols and all the, if there are some cells which are in the peritoneum to that particular port. So that's why we thought we will excise this port, and it is not going to do much disadvantage to the person when we are doing. Sometimes when earlier we used to do umbilical port, every port excision, then hernia incision were common, but only one port excision doesn't produce much. So based on that particular thing, we are excising one port which has been excised. If we are not able to get any message from the index operation, then we excise the epigastric port based on what our people are doing. Mostly everybody is taking from the epigastric port. Yes. So yes, sir.
At some stage we were doing and we were recommending excision of all four. That it probably is of no use except that it's site metastasis with PET scan showing no other disease. Then you may excise, but as both the speakers said, with great caution and counseling of the patient, that most probably there will be recurrence.
The point I'm extending is, if you did all this 12 or whatever, so many incidental GB cancer you would have done, tumor deposit.
Sir, we have found tumor deposit. We have not found in any of the patient. This is very clear. In one hour patient, we found some insignificant thing, but they try to say we can see some cells. Otherwise, we have not found any patient having tumor deposits on the port site metastasis. So probably incidental gallbladder cancer, that is happening if there is no residual gallbladder. So most of the patient, we are not finding any tumor at that time when you are doing completion extended cholecystectomy. So that logic might be working. When patients are coming in advanced stage and we are giving all these adjuvant and all, those are the different. When patients are coming in appropriate timing and you are doing completion extended cholecystectomy, so we are not finding residual tumor. We are doing based on the T stage.
Preemptively excising port is now we have all moved away. We have moved away from that.
You should say that it is not mandatory to excise on resurgery
port. You are not
Ports when
for the redo surgery to a specialized HPB center
what is
rather than doing
specialized surgeon now.
Rather than doing
they are also beginners. Many of them, they are all
no.
just completely.
The message should be that please listen. The message should be that don't trust opinion. The message should be that you excise the port when you are taking gallbladder out. Please use proper bag so that all bile spill and all those things which occur at the time of extraction should not occur. That message you can, if you use this with a caveat, or else what this consensus meeting sir is making, whatever you find, take a consensus and do it. But that is what is, that's all I am saying. That is what is the based on the what we are seeing the people coming, and that same logic we are trying to this thing. Everything doesn't require RCT. There are something you see by the experience also.
And use of bag is even I would recommend, because though Chelad pointed out that you don't need to mention that, but even in smaller nursing homes, so many times we get patients who have the gallbladder have been extracted without use of an endo bag. So every center or every smaller nursing home is not using a bag as for an extraction. They just remove the gallbladder. It is not for infection part.
Metastasis.
Correct.
So my point was not against the use of bag. I routinely use it. I advocate it. I was just mentioning it's not a panacea to reduce your port site meds, because it's not the one variable only. There are many other actors in this port site meds. And I request Prof. Kapoor to consider a post meeting some form of Delphi consensus for such topics where the evidence is scarce. As we have various viewpoints, and that viewpoints must be published and reported. The minority viewpoints shouldn't be suppressed.
Yes.
Because
absolutely.
absence of evidence doesn't mean evidence of absence. So we should get a consensus. We should say more than 80% or 90%. We should say that this is a strong recommendation.
Most Delphi, that's what they plan.
Yes.
Because in most questions which we have discussed so far, there is no evidence, and it seems that there is very little consensus also. So we will follow the Delphi process. I was reviewing the process of Delphi consensus. Most reports include 70, some have one up to 60 also, but I think we would take about 70.
So I think I go to our medical gastroenterologist. So Dr. Anurag, so what is your opinion about role of endoscopic ultrasound in the gallbladder, suspected gallbladder cancer or gallbladder this thing, gallbladder stone disease, both ways?
So whatever that an ultrasound, an abdominal ultrasound can do, an EUS can largely do it better. So EUS would have a higher sensitivity and specificity of picking up gallstones when compared to an abdominal ultrasound. EUS has a better sensitivity in predicting the nature of lesion. Of course, end of the day it's histology, but it does have a higher sensitivity and specificity in predicting the nature, whether it could be malignant or benign. For instance, when you just mentioned, what features one would look for while doing an abdominal ultrasound to say whether it is malignant or not. So if there is this intra-gallbladder lesion, there are certain features, and especially if there's a center which is doing contrast-enhanced EUS, then almost up to 80 to 90% specificity one can predict whether this lesion is malignant or not. And the features would there include the irregularity, the surface irregularity, and the irregular uptake of the contrast. So both ways it slightly scores over, and whether it is early gallbladder cancer or gallstones, the neck gallbladder stones are picked up with a higher frequency with endoscopic ultrasound. So in these two instances which you specifically mentioned, an EUS scores better.
So I was thinking about there are certain lymph nodes in the gallbladder cancer management which are clear-cut taken as a metastatic disease, and these are basically becomes contraindication to the curative surgery, or they are the one of the indications to go for neoadjuvant. We make our some protocol based on these things. So do you think that it is like autocoil group of lymph nodes, celiac group of lymph nodes, can it be done better handled rather than going for CT and all, or then staging lab and all can be avoided?
So the present CT scans do almost an equal job. But
No, I am
yes,
talking about FNA.
FNA, yes,
US
FNA from the nodes or FNA from the perilesional hepatic infiltration. These are two areas where EUS, of course, is the best. It scores over CT, it scores over abdominal ultrasound. So these two, the lymph nodes, especially the ones around the cystic duct and the perilesional infiltration, hepatic infiltration. The FNA done through EUS, nothing is even close to that, sir.
Yeah, so I thought this would be the better, you can do a US guided FNF if there is a suspicion on PET or these things, group of the lymph nodes which are, becomes contraindication to carotid intent are one of the indications to go for this thing. So I think sir asked me only one question to everybody, so I am going to ask Dr. Shahid Siddiqui. Dr. Shahid, can you just in short tell you where do you stand in terms of neoadjuvant therapy in a gallbladder cancer and adjuvant therapy? What regimen is being used and is it effective?
I am basically a radiation oncologist.
Okay.
So definitely there are reports in the literature that adjuvant treatment maybe in the form of radiation or post-surgery chemotherapy, they have a definite role to play in the management of the gallbladder malignancies, especially from 1B onward stage, and in the unresectable setting also, when the tumor is unresectable.
Palliative
Yes,
chemo.
that is for palliative tumor. As far as neoadjuvant radiotherapy or adjuvant radiotherapy are concerned, there are studies available in the literature in favor of both, and most of them are of course retrospective studies, and two of the studies are ongoing. One is the Jain study and the one is Paul CAGB. The results of those studies are still awaited and likely to be declared in next year or so. So, in the management, I mean, there is, of course, 1B onward, the adjuvant therapy can be given either in the form of concurrent radiotherapy or concurrent CRT, sorry, or maybe adjuvant RT also. But we have to wait for the results of the ongoing studies, unless we have planned RCTs in favor of either of them.
So one more thing I wanted to discuss, but because time is gone, but we have caused the, I think this was being discussed when I entered. When you see Dr. Anurag, when you see a patient with gallbladder cancer and surgical obstructive jaundice,
Sure.
so how you approach these patients? Suppose somebody refers that this patient is having surgical obstructive jaundice and there is a gallbladder cancer associated.
So for suspected carcinoma gallbladder presenting with jaundice, as we have seen, as goes by the literature also, they're largely unresectable. So the issue here would be largely palliative. Tissue diagnosis then in unresectable lesions, we have then options of either taking percutaneous or through EUS or while doing an ERCP. But most of these patients who present to us with jaundice and are unresectable are given endoscopic palliation in form of self-expanding metallic stents, a brush cytology taken at the same time.
So I think that is the Shivandri is also listening. We are little bit different opinion we have, and that is the message I wanted to give, that every gallbladder cancer presenting with the jaundice, I think we should put some effort to first say that this is not resectable. And there are many reports where if you have been able to achieve R0 resection by doing different variation in your approach, then outcome has been almost same. The question is that is what tomorrow maybe I have my slide where metallic stent has been put, and then we gave a neoadjuvant therapy, and we have been able to resect a young lady and R0 resection. I will show tomorrow in this thing. So this was the message. Shivendra is resecting obstructive jaundice patient. We decrease the jaundice. We try to see the liver volume, and if at all confluence, it is below the confluence. Usually common site is close to the confluence, basically on the right side. But if it is below the confluence, by decreasing jaundice, we just took two segments, 4B and 5, and then do CBD excision, proximal and distal margin frozen, and do proper lymphadenectomy, and then go for adjuvant. So this can be done in a very small group of patient, and another group would be that where you have to, because of the right hepatectomy, that will include at least segment 4B preserving right hepatectomy or right extended hepatectomy. There There we are little bit failing because by the time our patient become ready, the disease become metastatic.
So in that scenario,
which is why I mentioned unresectable. Of course,
Yeah.
before hopping on to stenting these
Yeah.
patients, one would assess the resectability.
Yeah.
sir, in that scenario, what will you prefer? You will prefer PTBD to relieve the jaundice or metallic stent? Because-
Metallic stent, what we are, I think, getting confused in pancreatic cancer and gallbladder cancer. For gallbladder cancer, to have a metallic stent, it's not something lower down where you go above the, that particular small metallic stent and they resect. Here you have to go either both sides or you have to go above the, usually the site is common hepatic duct and above. So you have to, your metallic stent will go inside the either right duct or left duct. And here in that area, lots of reaction is there and very difficult to go around the common bile duct and resect the common bile duct and resect from the portal vein. So I think we go for plastic stent. If our gastroenterologists are nowadays, they are trying to go at the without blockage of the confluence at type 3 type blockage. But PTBD is commonly done if confluence is blocked still in our center. Sir, if to house, please ask whatever points we have discussed. I don't think it was anything more than what already whole day it has been discussed, but if you have any question, we can still try to answer. Or I will just close the session. So if not, then thank you all, and thank you all the panelists. Thank you.
Thank you, sir.
Thank you, thank you.
Thank you all very much.